Good morning, everyone. Today we're going to talk about COVID. So it's going to be presented by me first, and then followed up by Khalid, who's going to do the critical appraisal. So just full disclosure, we have no actual or potential conflict regarding this presentation. So the study we picked today was post-exertional oxygen saturation as a prognostic factor for adverse outcomes in the patient attending emergency department with suspected COVID. It's a sub-study from the priest observational cohort study that was done in the UK. So the priest study is, priest basically stands for a pandemic respiratory infection emergency system triage. It's a multi-center observational cohort study developed and used to evaluate triage methods for patients with suspected COVID. So in this sub-study, the aim is to evaluate post-exertional saturation as a prognostic factor for 30 days outcome. Based on recent literature, post-exertional saturation has been used to evaluate clinical severity of multiple conditions like COPD or pulmonary fibrosis. And it has been shown like a 3% decrease in oxygen saturation is cause for clinical concern, basically. So this study was aimed to test if that works for COVID as well. So the methods was, it's prospective or retrospective data collection from over 70 emergency departments in the UK. It measures a post-exertional saturation either by a 6-minute walk test or rapid sitting and standing 1-minute test, or it can also be used to measure opportunistically, like if the patient exerts themselves, they measure the oxygen saturation and see if there's a difference. And the 30-day adverse outcomes was reviewed by the research staff. So in terms of inclusion criteria, it was mainly for suspected COVID-19. So we all know the criteria: fever, cough, sore throat, basically flu-like illness, or any patient that presents with a life-threatening disease that infects a suggestive infective process. That they were included in the study, and as well as like clinical suspicion from the attending physician. So in terms of adverse outcomes, they were labeled as requiring like respiratory ventilation assist, mechanical ventilation, BiPAP, or non-invasive mechanical ventilation. This does not include oxygen supplementation or bronchodilators. The other one was cardiovascular support, so inotropes, ECMO. It does not include IV fluids or renal support, so hemodialysis, hemofiltration, peritoneal dialysis. Also does not include IV fluids. And lastly, death. In terms of exclusion criteria, was the age less than 3 or patients who are unable to cooperate, like wheelchair-bound, bed-bound patients. They had a baseline oxygen saturation of less than 85 or post-exertional less than 50 and also receiving oxygen. If the GCS was less than 14, they were also excluded. And from that inclusion criteria, group A was developed, and then data regarding sensitivity, specificity, and likelihood ratio was analyzed over a range of positive thresholds, and confidence intervals used using the Bedrick and Koopman methods. They developed a ROC curve, which is a receiving operator characteristic, and there's a slide later on that shows what a ROC curve is. And basically the area under the ROC curve gives you a C-statistic value. And like I said before, 3% desaturation has already been decided as a cutoff or cause for concern. And later on, they developed a multivariable logistic regression model to add to that primary analysis for parameters assessing if there's any prognostic value in terms of post-exertion oxygen desaturation. So these parameters included age, baseline oxygen, rest rate, heart rate, asthma, or any other chronic lung disorders, and obviously the post-exertional oxygen saturation. And then from that primary analysis with the multi-regression variable module, a secondary exclusion criteria was added, including patients who were less than 16. Their baseline oxygen was 94, and again, performance status limited self-care. or scoring 3 points or more on the new score. And the new score is a very common score used in the UK and Ireland. It basically measures all the vitals and it plots it on a graph or a score. The higher the score, obviously, being the sicker the patient. So in terms of results, in the original pre-study recruited over 20,000 patients. In this sub-study, 874 patients were included. 75 were later on excluded due to unfeasible measurement, either by the oxygen saturation or they just didn't fit for the study. So a total of 817 patients were analyzed. So in this table, it summarizes the statistics in terms of baseline oxygen saturation, post-exertion saturation, and the difference in all of the patients with adverse outcomes, no adverse outcomes at all. And it shows that it tended to be lower than the baseline oxygen saturation, showed a greater decrease in those who suffered adverse outcomes. But it has been noted that some patients had post-exertional increase in oxygen saturation, and this tended to be usually in the more sicker patients, just because there's a greater variable in terms of oxygen saturation measurement. So if you can get a change in measurement rapidly in more sicker patients. So that's why they developed the secondary exclusion criteria to test this on less sicker patients, basically. So we mentioned the ROC curve before. So in the graph on the left, it's in the primary analysis for the first exclusion criteria. The C statistic is the area under the graph. And for the primary analysis, the C statistic was 0.589, which didn't show any significant value in terms of prognostic information added. And the one on the right is for the secondary analysis group, showed a C statistics of 0.699, which indicates a better prognostic discriminant value in this group. This histogram also shows oxygen saturation pre and post exercise in both groups. It shows that there's considerable overlap between those with and without adverse outcomes. In terms of accuracy of the sensitivity and specificity, in this table, it's the primary analysis group, which shows a positive likelihood ratio of 1.78 and negative likelihood ratio of 0.67, which adds a small amount of prognostic information in terms of the primary analysis group. And this is in the secondary group. And they use thresholds of, as highlighted, 3 or more % oxygen desaturation. The second group, a likelihood ratio of 1.98 to a negative likelihood ratio of 0.61, provides provides a better prognostic value in terms of desaturation. Figure 2, it shows an overlaid histogram. So as you can see, the adverse outcome is labeled in pink and the no adverse outcome is in blue. And we see this very commonly in the emergency. Patients tend to have lower oxygen saturation, are usually sicker. And this is just for the baseline oxygen saturation. The next graph shows for the post-exertional desaturation. So you can see there's more added information in terms of adverse outcomes in patients with post-exertional oxygen desaturation. So in terms of the results, basically the primary analysis cohort group did not add any prognostic value with a p-value of 0.379. And the secondary analysis cohort group, evidence shows modest prognostic value with a p-value of 0.019. So post-exertional saturation, if applied correctly on the correct patients, can add modest prognostic information. It can be easy to incorporate in patients. The appropriate patients would be the less sicker patients, i.e. normal baseline vitals and oxygen. In the absence of desaturation in low-risk patients, can be reassuring in terms of discharge. But as noted in the study, further research using more controlled approach may provide more useful prognostic value than the one used in this study. There was also like a possible selection appropriate bias in terms of the appropriate patients because it was either like clinical, physician based. But from what I took away from this is that obviously in the emergency, like we use more lab values, chest X-rays, just clinical suspicion on which patient is the sicker. So in this prognostic value, it's really not that important. It's usually for the less sicker patients, the patients that you're over the fence with, or whether to discharge home or not. That could go either way. Post-exertional oxygen desaturation, you get them to sit and stand for like 1 minute, see if there's a 3% decrease of oxygen saturation. You might have to think a bit twice, just because there may be a 30-day adverse outcome. So thank you. I'm going to pass you over to Khalid now. He's going to continue the presentation.
Hi, can everyone see my screen?
Yes, we can, yeah.
Okay, so just give me a second. I'll just open the chat. Yeah, I can see the chat. So if anyone has any question, just type it in and I'll see it. Okay, so my name is Khalid bin Ghannam. I'm a FRCP R3. I'll continue the presentation that Reda started. So thank you, Reda, for the brief summary. So the study, so let's talk about the study. I like to present in more interactive way. So I'll ask you questions. If you could answer or just type it in the chat, that would be appreciated. So the clinical question for the study was, does post-exertional oxygen saturation assess the severity of suspected COVID infection? Meaning that is there an outcome or adverse outcome within the next 30 days? And the bottom line would be the author concluded that there's actual positive likelihood ratio of decrease in oxygen saturation post-exertion in patients suspected COVID attending the emergency. So my first question is, uh, sorry, why is this reading? Yeah. So did the study address a clearly focused issue? What do you think, guys? Just type it in. Was there a straightforward question that the study addressed? Yeah. Yeah. So yeah. Yes, so basically the study had a specific goal in mind that they wanted to talk about, which is clearly the post-exertional oxygen in suspected COVID patients. So the second one is, which is the $1,000,000 question in cohort and observational studies. Was the cohort recruited in acceptable way? Uh, I don't think Reda talked a lot about the recruit. He talked about the inclusion criteria, but not the method. And I'll talk about the method. So personally, I don't think the recruitment was appropriate in this study, and I will show why. So the way they recruited the patient was basically their study was in 70 different emergency department, and some department were doing it retrospectively, others were doing it prospectively. So in the retrospective cohort, as you can see, it was a chart review, and the physician who did the post-exertional oxygen saturation was just part of a routine care. And so basically out of the 874 patients who came with suspected COVID, out of 22,000, only 800 that actually they had information about the post-exertional. That tell me there is uh, a large number of selection bias in the study, and the other cohort or the other sites where they did the post-exertion prospective type of collection, there was no criteria or standardized criteria. It's basically based on the clinician's decision whether or not to measure the post-exertional oxygen. I don't think that's appropriate. A lot of physicians don't do that, at least here. I don't know about the UK, but in Canada, I have never seen anybody does that, measure the post-exertional oxygen saturation. So the next question is, was the exposure accurately measured to minimize bias? Any thoughts? I mean, it's an accurate way to measure the exposure. The exposure was the exertion and the oxygen, so it was measured in an appropriate way, in a subjective and accurate way, which is the oxygen saturation. And they have a standardized method, which is the either a 1 minute to sit or 6 minute or 40 step test, which is accurate and standardized. So I think it's standardized across all the cohorts, and I don't think there is any bias in this particular step. Next question is, did the did they use objective measurement for the outcome? Well, we know that Reda spoke about the outcome, which was the 30 days outcome in cardiac, renal, and respiratory outcomes. So I think that they actually did, because they had a standardized way and objective method, which is they went through the chart review of everybody who were enrolled, and then they will exactly look for the outcome, which is either in respiratory or cardiovascular or renal, which they exactly looked for either ventilation support, or they looked for even ECMO or ionotropes use. So I think that they actually looked into it in an objective way for the outcome. So the next question, which yeah, I sort of answered the question. Are these outcome reflective of COVID? I want to hear the thoughts of everyone. If someone can take this, and why I think it's maybe could be reflected or not. But can we hear from the audience? Someone could tell me their thoughts whether or not this can be, because I never heard of this in COVID, the post-exertion, until I read this article. Anyone? Any thoughts?
I may have.
Yeah, go on, Mustafa.
Yes, I may have missed this during the discussion, but it's more of a question. Is that specific to COVID patients or not? So if a patient that comes with COPD, could be COPD exacerbation, they could be desatting because they have COPD exacerbation, they could have pneumonia. If the authors were sure to exclude these patients, I may have missed this point. If not, then the outcomes may be not be reflective of COVID-19 patients.
Yeah, that's exactly my thoughts. Post-exertional, apparently this is something weird in the UK. They do that where, sorry, Robert, where they measure the post-exertional oxygen saturation in certain patients who comes in the emergency. And it can be used in the clinic, certainly, for the prognosis. For COVID, for interstitial lung disease. It can be positive in many things. And unfortunately, in the study, they did not exclude these patients. And the enrollment was patient walks into the emergency, they're suspected of COVID, which is 70% of the people who walks into the emergency these days, and they are already enrolled. And and they will follow them for the outcome, which is 30 days from the enrollment, which at that time they would have enough time to confirm whether or not these patients are COVID positive or not. And they did not mention that in the study. At least I didn't come across it. So we don't know if this patient decided because of COVID or because of COPD or CHF or pneumonia or anything. So is it really reflective of COVID? Maybe, maybe not. It's hard to tell from their paper.
I mean, Khalid, my understanding of, sorry to interrupt you. My understanding of using such a test, I've used it before in kind of patients outside of COVID, like who you're worried, who, like they may be off oxygen but are looking kind of vulnerable. And the reflection is really more of underlying physiology of either a VQ mismatch or shunt physiology, which can be seen in a variety of issues. So if you have somebody with COVID, and you do the walking desaturation test, it's a reflection of their underlying lung physiology at that point, but not necessarily specific for COVID. So in the end, it can tell you whether this person might be someone who is too vulnerable to go home. And agree that in the emerge sometimes it's hard to do, but if we have walking saturometers, it's an easy thing to do if you can get the physio to do a walk test and do the saturation at the same, or a nurse at the same time. It tells you kind of valuable discharge information in general, is my understanding.
Yeah. But is it really reflective of COVID? If they rephrase the research question to the outcome in patient with respiratory distress, that would be a better question, a better or more reflective of the study, or better study question. But they said suspected of COVID, which I don't understand why. I don't get it why they specifically said suspected of COVID and did not say confirmed COVID, or they retrospectively or prospectively confirmed that they are COVID. But yeah, apparently Dr. Christine Mayer do that, or she measure the post-exertional oxygen, but I have never worked with a staff that actually requested it in my 3 years of residency. I've never seen it, to be honest.
So Khalid,
Yeah.
I did this last evening in the emergency in an asthmatic COVID patient. And the scenario was Urgence Santé had actually measured his O2 sat at 89% on room air. I see him walking into the room looking great. And the nurse got an O2 sat of 94%. So I kept him off the oxygen. It remained at 94%. He went for x-ray. So I said, okay, walk to the x-ray, walk back, and took the O2 sat again, still at 94%. So from the respiratory point of view, I knew he was okay to go home, whether it was COVID or asthma. And I think a number of us do this test. You just probably don't see it.
Well, that's something I honestly did not see anybody, or not even noticed until I read this article. But good to know. I thought it's mainly done in the clinic in sort of like a lung, because I was reading about it in interstitial lung disease or COVIDY, where they risk stratify and they predict the long-term and short-term outcome where they do this, but I never seen it in the emerge personally. But yeah, good to know. Thank you, Dr. Doyle. Yeah, Dr. Mayer mentioned that it should be a factor only to measure when deciding to discharge. Okay, moving on. So, has a reliable system been established to detect all the cases? I would go with no, because their recruitment was mainly, they had no standardized way. So there's about 22,000 people with suspected COVID, and only 800 of them, which is 3%, enrolled. And the second problem was which I'm gonna talk about later on, is let's say a patient came in and they had post-exertional saturation was normal, they looked well, they were discharged, there were no system in place to follow up with them. Maybe they died 10 days after, but there's no way. They only collected data for the patient who were in the hospital admitted for the 30 days, but no system in place for the patient who were discharged. So I would go with no in this question. So have the author identified all the important confounding factors? I think Mustafa mentioned that. So I think they did identify some in their primary and secondary analysis, but not all the confounding factors. They were talking about suspected COVID and they mentioned exactly COVID. So I think that there's a lot of confounding factor that they can exclude or identify and exclude in their analysis and their study structure. But I think they did not talk about the pre-existing lung and cardiac disease that they may cause desaturation, post-exertional desaturation. Robert, you wanted to say something?
No, I didn't.
I heard something. I thought it was it. Have the authors identified important? Yeah, we went through that. Maybe they identified some of them and some they did not, which Reda already talked about. So do you believe in the results? Any thoughts? Would you consider this study solely as something that may influence your decision based on their method? Any thoughts?
I think, I mean, the study's okay, and it's an interesting question. I would honestly say that I'm a little bit disappointed that the predictive accuracy of this test is actually kind of worse than I expected. I mean, the sensitivities and specificities are actually really quite poor. I don't think you can meaningfully use them to significantly influence your clinical decisions.
Yeah, I think post-exertional oxygen saturation has been used in respiratory illnesses. It's not the first time and it was validated before, but using this study, honestly, like I think the method, if we have a better, the study is okay, as Robert said, but if they used a better controlled study, I think I would use it in respiratory illness, or someone with respiratory distress who comes to the emergency and may or may not be discharged, and they might use it, but the study is not well controlled and there's so many confounding factors. Someone with post-exertional saturation, they may have underlying lung disease that's why they died 20 days from now. That's why they were intubated, not necessarily because of COVID or the current presentation that they have right now. So that's my thoughts, but we can see that there's some correlation with post-exertional decrease in oxygen saturation and adverse outcome within the next 30 days. So yeah. So one more question, the last question, or I think we have one more question after this one. So does the result of this study fits other available evidence? Yes, it does. We already know that post-exertional oxygen saturation can be used in other, but in COVID, there's only one, which is the original priest that shows that drop in oxygen saturation that can predict or used in risk stratification. But so yeah, it does, but we still need more than this study to firmly say that's an important indicator for the adverse outcome within the next months. Last slide or last question. What are the implications of this study for the practice? So any thoughts? I think we already discussed this. I think Dr. Christine Mayer mentioned this before, which is if you are thinking of discharging a patient and you feel like they're well, and you may do the post-exertion oxygen saturation just to see if they're still saturating well after 6 minutes of walk to make sure that they're safe to be discharged. But still, I think that we need more studies, especially in the emerge, to implement this, and we need a better study structure for specifically COVID or a certain condition with control of other confounding factors to answer this question better. And you could always use other tools like a chest X-ray or blood tests or inflammatory marker, or COVID blood tests, or anything. If you're thinking of COVID or something else, to better risk certify the patient, not solely use the post-exertional oxygen saturation. Thank you, everybody. Any last thoughts before we conclude? Okay. Thank you, everybody. I'll leave it to Robert.
Thanks, Khalid. That's an interesting topic. And I guess, I mean, hopefully going forward, we're going to see less and less COVID. But it's interesting the point you raise about might this be useful in other conditions. I really am not aware of the literature around this, but if this is a useful risk stratification tool for other conditions like CHF and COPD, maybe it's something we may end up using for other things. I don't know. Okay, I don't know if anyone has any other final comments about this. Maybe we'll take a few minutes break. We're a bit ahead of schedule. So why don't we come back in 15 minutes time at 9:45 for Kate's talk about cannabinoid hyperemesis.